Thank you very much. I'm going to talk about the maternal deaths from general medical and surgical conditions, and I'm doing this on behalf of a larger chapter writing group. So the deaths in this chapter consider those medical conditions except those from cardiac disease, neurological disease, sepsis, and other infections, including COVID and cancer. And these other indirect deaths make up quite a large proportion of late deaths, and many of these women died between 6 weeks postpartum and 1 year after the end of pregnancy, 7%. And it's worth noting at this point that of all the women who died, 55% of them, that's from direct and indirect causes, actually had pre-existing medical problems. And many of these women who died, as you will hear, had a known medical diagnosis. So this is the top line. This chapter considers 43 deaths, and the commonest of these causes was deaths from endocrine disease, followed by deaths from hematological disease. I'm going to discuss these in more detail now. Firstly, the deaths from endocrine disorders. 8 women had diabetes, and 5 of these women who died with diabetes did so from diabetic ketoacidosis. And you will remember that this was a theme last time deaths from diabetes were considered. Women are no longer dying from hypoglycemia, but women with diabetes are dying from diabetic ketoacidosis. 2 women died from Addison's disease, and then there were several deaths from rare endocrine disorders. And most of these women actually were late deaths after 6 weeks postpartum. Only 6 of them died while pregnant or within 6 weeks after the end of pregnancy. And this is the first vignette. This was a vulnerable young woman with type 1 diabetes who had an unplanned pregnancy. She had no financial and little emotional support. Prior to the pregnancy, she'd been under the pediatric endocrinologist with a pediatric insulin regime. She'd not attended diabetes clinic regularly. She booked early and was converted to the adult regime at the end of the first trimester. However, this led to multiple hypoglycemic episodes. She was admitted with DKA on several occasions during the pregnancy. She had a cesarean section in the early 3rd trimester because she had poor glycemic control. And after discharge, she had some midwifery visits, but she declined the health visitor visits for vulnerable mothers. She found social services involvement threatening, and she was admitted to hospital 2 months postnatally, but not with her baby. She had another ketoacidotic episode, but she didn't have her baby with her, and she self-discharged. She then changed GPs, never saw her new GP, and she died from diabetic ketoacidosis at home a few months later. This case and others has led to a new recommendation that we should ensure that guidance on the care for pregnant women with complex social factors is updated to include a role for the network maternal medicine care, and importantly, postnatal follow-up to ensure that that care is tailored to the woman's individual needs, and that resources in particular target vulnerable women with both medical and mental health comorbidities and social complexity. And one of the new key performance indicators for the maternal medicine networks I've shown for you here, it's 1B, and it says that we're going to count the percentage of women who've been referred for care or an opinion to the maternal medicine centre. And wherever feasible, they should have a care plan that includes postnatal care and the handing back of that care to appropriate physicians. But there have also been previously published recommendations from NICE, from the MBRRACE inquiries, reiterating what we've said about this case, that women with complex physical and psychological comorbidities need care before, during, and after pregnancy. The previous published recommendations are summarised for you here. This woman was known to have adrenal insufficiency prior to her becoming pregnant. She had admissions with adrenal crises before pregnancy and several documented episodes in the pregnancy. She saw her endocrinologist regularly, who increased her medication appropriately and ensured a supply of emergency hydrocortisone. The endocrinologist documented repeatedly that she had severe nausea and vomiting from early in the first trimester, but no plan was made for antiemetic therapy, despite the fact she was unable to keep her oral medication down on multiple occasions. There was minimal communication between the obstetric and endocrine teams. She had an uneventful labour and birth and was discharged the next day, but she had a low sodium level, and this is a marker of poorly controlled Addison's. She also had various concerning symptoms postnatally, including a further episode of nausea and vomiting, and she sadly died from an adrenal crisis shortly after being discharged to community midwifery care. So this led to another recommendation that we must ensure that staff working within the maternal medicine networks are equipped with the skills to care for the complex and multiple medical, surgical, and mental health and social care needs of the current maternity population. It's also led to an adjustment of the recommendations in the new RCOG Green Top Guideline for the management of nausea, vomiting, and hyperemesis. And this recommendation deals with which patients require inpatient care. And the recommendation says that women with hyperemesis should be admitted for inpatient care if they have comorbidities such as epilepsy, diabetes, and we've added hypoadrenalism, HIV or psychiatric disease, where the symptoms and an inability to tolerate oral intake and their medication could present further complications. In other words, if women who are dependent on oral medication are not able to keep that medication down, then they must be admitted to hospital so that they can have appropriate aggressive management of their hyperemesis and also alternative routes of administration of these essential medications. So this guideline isn't actually released yet, but I very much hope that it will be released by the end of this year. But this is what the recommendation currently says. Similarly, there have been other previously published recommendations about women with complex medical conditions and the need to involve multiple specialties. But what went wrong in this case was the communication between her obstetrician and her endocrinologist. And this is where there needs to be a project manager, and somebody needs to show leadership and responsibility for coordinating the care of women with these complex medical conditions. This case deals with a woman who was known to have a thyroid disorder. Several months after giving birth, she had a large baby. She presented with fatigue, dizziness, weight loss, and acidosis. So it was assumed that she must have developed diabetes, a known association with thyroid disease. But she had a persistently normal glucose tolerance test and a persistently normal HbA1c. She was also noted to be tanned. The diagnosis of Addison's disease was not considered, and this woman died 7 months postnatally of severe ketoacidosis of unknown cause. And I suspect the assessors and myself thought that this woman actually had undiagnosed Addison's disease. The next group of deaths were from women who had a hematological cause. 3 women died of thrombotic thrombocytopenic purpura, known as TTP, 2 from hemophagocytic lymphohistiocytosis, known as HLH, 1 from thrombotic microangiopathy, and 1 from an occlusive vasculopathy. Now, these are rare conditions, and most of them died during pregnancy or within 6 weeks after the end of pregnancy. The references shown for you there give good summaries of the presentation and management of HLH in pregnancy. And many of you will remember that for the last 3 inquiries dealing with indirect deaths, there have been deaths due to HLH. We now have a test, Adams T13 for TTP, and the test to remember, you won't diagnose TTP or HLH unless you think of it. So just a little helpful hint. For TTP, you need a blood film. And then if there's a microangiopathic hemolytic anemia, you should send off the Adams T13. For HLH, you need to suspect it. It presents with fevers of unknown cause, and you need a ferritin. And the ferritin is normally well above 10,000. And then you need to use the H score, which is described in those references. So these are rare. Most midwives and obstetricians will never encounter them. It's a question of thinking, when you don't know what's wrong, think of these rare conditions. because treatment can make a difference. The deaths from the other medical disorders comprise 2 deaths of women from connective tissue disorders, 5 from respiratory disorders, including 4 from asthma, and 6 women died from gastrointestinal disorders, 4 from pancreatitis. This woman was high risk. She was known to have asthma and she had repeated visits to the emergency department with threatened miscarriage and shortness of breath. She was documented as saying she was using her reliever inhaler 8 to 9 times a day, but instead of giving her treatment, she was advised to see her GP. It's unclear if her respiratory team knew that she was pregnant, and early in the 2nd trimester, she had an asthma attack and a cardiac arrest. She was resuscitated, admitted to intensive care, but she had a miscarriage and died a few days after her admission. This is an old recommendation, and it says it's from the Scottish Intercollegiate Guidelines Network and the British Thoracic Society Guideline on Management of Asthma, where there's a chapter on management of asthma in pregnancy. And it says that you should monitor pregnant women with moderate to severe asthma closely to keep their asthma well controlled, and that acute severe asthma in pregnancy is an emergency and should be treated vigorously in hospital. But here again, it was not thought that the asthma was the responsibility of the doctor assessing her in the early pregnancy unit. It's everyone's responsibility. This woman was in her 2nd pregnancy. Again, she had a complex social history and multiple medical conditions. She was booked for antenatal care in a joint diabetes pregnancy clinic and with the asthma team. Her glycemic control was poor. She had multiple hospital admissions with asthma in the late 2nd trimester. She was admitted to a high dependency unit, again with diabetic ketoacidosis. She had a cesarean birth, which was preterm, and 9 months after giving birth, she had a cardiac arrest at home and died. So here we have restated previously published recommendations, including the fact that women with pre-existing medical conditions should have pre-pregnancy counselling by someone experienced in managing their disorder in pregnancy. And that the Ockenden inquiry said that the development of the maternal medicine specialist centres and the maternal medicine networks should be an urgent priority. Well, happily, that's now happened. But we need high-level actions to ensure that it's seen as the responsibility of all health professionals to facilitate opportunistic counselling and framing. And clearly, this woman with severe diabetes and severe asthma needed pre-pregnancy counselling. Remember also that these women with complex medical conditions need access to effective contraception. This woman was multiparous. She died 10 months after giving birth to her 2nd child because she had a fungal infection and also had underlying autoimmune hepatitis. She presented at term with itching. Bloods were taken. She was found to have elevated transaminases, but because she didn't meet the diagnostic criteria for intrahepatic cholestasis, there was no follow-up. And 4 months postnatally, she developed jaundice and again had itching, and that was attributed to shingles. She then got referred to a hepatologist, had a liver biopsy, and was diagnosed with autoimmune hepatitis. So this was closed box thinking. She was under the obstetricians, she had itching, she had abnormal liver function tests, and she did not have intrahepatic cholestasis. She had undiagnosed autoimmune hepatitis. She should have been followed up. And therefore we restate the recommendation made previously. The emphasis should be on making a diagnosis, not simply excluding a diagnosis. This pertains to pulmonary embolus, it pertains to obstetric cholestasis, it pertained to the previous example I gave where it was thought that the woman had diabetes. You must make a diagnosis. This woman did not have cholestasis. She had an underlying liver disorder. This woman had ulcerative colitis and she died 6 months after giving birth. She had a necrotic stoma and she'd previously had a subtotal colectomy and ileostomy prior to the pregnancy. She presented 3 times to the emergency department for abdominal pain and possible blockage of her ileostomy. She was admitted under the care of the surgeons and managed conservatively. After she gave birth, a new GP advised her to seek medical advice if she had new onset abdominal pain and referred her to gastroenterology, but it's not clear whether that appointment took place. There was no postnatal surgical involvement. So in many instances, as in this woman, the assessors noted the need for coordinated multidisciplinary care that utilises expert advice, including through the maternal medicine networks where these have been established. This woman's care was appropriate and multidisciplinary during her pregnancy, but it all fell apart postpartum. Multiple blockages of an ileostomy can lead to strictures and necrosis, which increases the risk of rupture. This woman had multiple comorbidities, repeated bowel complications during pregnancy that would have benefited from a clear postnatal plan for follow-up with a multidisciplinary team to include a gastroenterologist, a dietitian, a tissue viability nurse, and possible surgical consultation. Every time that these other indirect and surgical deaths are considered, we have deaths from splenic artery aneurysmal rupture. And this year was no exception. There were 4 deaths due to splenic artery aneurysmal rupture and 2 from other bleeding sources. And all these women died while pregnant or within 6 weeks after the end of the pregnancy. This was one case. This woman was in her 4th pregnancy and she collapsed early in the 3rd trimester with abdominal pain. She was taken to the emergency department. She was hypotensive, had an elevated respiratory rate, and was found to be profoundly anemic. Placental abruption or perhaps an aortic dissection were considered, and plans were made for a diagnostic CT, but that never occurred because an ultrasound showed an intrauterine death, and she therefore got transferred for an emergency caesarean section, presumably because they thought the diagnosis was placental abruption. But when her abdomen was opened, there was fresh blood in the peritoneal cavity and no source could be immediately identified. A vascular surgeon was called to identify the source of the bleeding, but couldn't, and a ruptured splenic artery aneurysm was only identified post-mortem. This is an old recommendation. If women of reproductive age present to the emergency department collapsed, a fast scan must be performed. That stands for a focused assessment with sonography in trauma, and this is to exclude intra-abdominal bleeding, especially if the woman is anemic. This is also relevant if the diagnosis is felt to be a PE, because you don't thrombolyse someone who's got intra-abdominal bleeding. And in this case, this would have avoided a caesarean section and transfer for that, and identified the intraperitoneal bleeding. So I'll finish there and wish to thank the other members of the writing group, and thank you very much for your attention. I'm happy to take any questions.